So, good morning, good afternoon, and good evening. Welcome to the ninth episode of our Global Connect webinar series. My name is Chilla Myers, and we are privileged to have a global audience from 26 different countries joining us today. We are excited to be connecting with all of you. Thank you for our returning viewers, and welcome to those of you who are tuning in the first time. We would like to ask our valued audience to complete a brief survey at the end of this webinar, and so we can listen to your feedback on our future episodes. Our moderator is Dr. James Stoller, Chairman of the Education Institute at Cleveland Clinic. Dr. Stoller, I'm turning it over to you.
Oh, well, thank you, Chilla. And again, let me welcome all of you. Good morning, good afternoon, and as Chilla said, good evening. We're connecting with colleagues all over the world, I'm delighted to say. And we've assembled really a panel of blue ribbon experts from around the world in education to take on the issue in our webinar today of medical education during a pandemic. We'll call up that slide. I'm going to ask every member of the panel, all of whom are deep experts in clinical medicine and medical education, to introduce themselves. We have representatives from the Cleveland Clinic in Cleveland, from Cleveland Clinic Abu Dhabi, and from Mohammed bin Rashid University in Dubai. We'll start with Dr. Isaacson. Dr. Isaacson, please introduce yourself, and then we'll go to Dr. Foshee, Dr. Traboulsi, Dr. Abdel-Razig, and Dr. Alawi, Dr. Alawi, Alsheikh-Ali, in that order, please. So good morning, Bud.
Yeah, good morning. Bud Isaacson here. Privileged to be here and looking forward to the conversation. I'm a general internist in Cleveland, and I'm the executive dean of our medical school. And so I think the issues that we've had to deal with have primarily been how do you manage training medical students during a pandemic, and how do you make sure they stay on track to meet their graduation requirements while keeping them safe and not allowing them to become vectors of the disease. So it's been a challenge, but we've gained some insights, and I look forward to the conversation and to sharing it with all of you. Thanks.
Great, thanks. Cecile? Good morning.
Hi, good morning, good evening, good afternoon. I'm Cecile Foshi. I am also honored to have been invited to this panel and delighted to be here. I am a medical educator. My PhD is in educational technology. I'm director of GME Learning Innovation. I also lead our Masters of Education program and co-lead the Office of Interprofessional Learning. So my audiences actually expand the gamut of health professionals. You know, work with physicians, both staff and trainees, nurse practitioners, nutritionists, therapists, and so on. It's part of the beauty of being at Cleveland Clinic. So I hope to be able to share some of those insights with you.
Thank you, Cecile. Alawi, may I invite you to introduce yourself?
Thank you, Dr. Stoller, and it's great to be with you and with the colleagues. My name is Alawi Alsheikh-Ali. I'm the University Provost and the Dean of Medicine at the Mohammed bin Rashid University of Medicine and Health Sciences here in Dubai. We are a new university and a new medical school. We were in the middle of our fourth academic year of existence into a 6-year program when the pandemic hit. So I look forward to learning from colleagues here and sharing some of our experiences on how we dealt with this and how we continue to deal with it.
We're delighted you've joined us. Thank you. Sawsan, colleague from Cleveland Clinic Abu Dhabi. Good morning, good afternoon.
Good morning, and I'm excited to be here. I'm Sausan Abdel-Razig. I'm the designated institutional official here at Cleveland Clinic Abu Dhabi. I'm also a hospitalist and the chair of medical education, and most of my work is in the realm of graduate medical education. So I'm really excited to listen to your insights and also partake in the discussion.
Well, we're delighted you're here, Sausan. And our own designated institutional official here in Cleveland at the Cleveland Clinic Abu Dhabi, Dr. Elias Travolta. Elias, good morning.
Good morning, everyone. And I'm also extremely happy to be with all of you today. I am Director of Graduate Medical Education at the clinic. I've been in my position about 15 years now, formerly Program Director of Ophthalmology. I'm a pediatric ophthalmologist and geneticist, and I'm very lucky to work with the team at the clinic and to collaborate with colleagues from around the US and around the world. So I hope I can contribute something to this discussion today.
Oh, undoubtedly you will. We look forward to your comments. And again, my name is Jamie Stoller. I'm a lung doctor at the Cleveland Clinic, and I serve, as Chilla mentioned, as the chair of our Education Institute. Briefly, the Education Institute really integrates all of the educational functions. So the medical school, graduate medical education, continuing medical education, international medical education, allied health education, simulation, et cetera, working closely with our nursing colleagues. So we enjoy an integrated educational structure. And that's the context in which I and my esteemed colleagues on this call can address your questions. So what we've done today is we've assembled collectively about 3 questions that we think in general address this issue. And I'd like to just show those questions, read them, and then I will put those questions in play to our panel. I'm mindful that we've also received from you in your registration material some questions, and we'll commit to addressing those as well. The first of the 3 questions that I'll address to our panel in whatever order they wish is, in what ways has the pandemic caused you to change your educational approach? To which educational audiences and how so? That's the first question. The second, please. What's been the impact of the pandemic on virtual education? We've all morphed to teaching virtually as we are engaging virtually now. How are you using virtual education currently, and with what impact? Any specific recommendations about approaches to virtual education, platforms and techniques? And the third question is, what educational opportunities and innovations have resulted from the pandemic? Please describe. The last question gets to the oft-quoted, a crisis is a terrible thing to waste. And so each of us in our respective worlds has been adjusting to this new world, but seeing opportunities in that environment. So with those 3 questions, let me read the first one again. We'll bring our faces up, please, Chilla. Let me put in play to the panel, in what ways has the pandemic caused you to change your educational approach? To which educational audiences and how so? And I invite comments from our esteemed panel.
Maybe I could start with the medical school. We were faced really in mid-March with the fact that as the pandemic unfolded, the national guidelines in the US really said we needed to pull students away from patient care, at least temporarily. So we were faced very suddenly with the fact that students no longer could be involved with our clinics or our hospitals. And we also couldn't bring students together for their usual education. So we were forced to pivot very quickly, as most organizations and universities were, to a virtual platform for seminars and in-person learning. But our real challenge was, how do we keep medical students on track for graduation when they can no longer be involved with patient care? So our approach briefly was to use a lot of online resources where we could fit them in to educate about medical content. And we were able to pivot with, I would say, mixed results to virtual visits, which our providers were doing. And we tried to integrate students in both an outpatient virtual visit world and inpatient, where the students would actually dial in through video and participate both in clinic visits and hospital rounds. It was with mixed success. We then really looked at what parameters we had to put in place to safely redeploy our students. And by June 1st, we had agreement across the city in Cleveland, the various hospitals, on various maneuvers and strategies that would need to be put in place so that the students could safely go back in. And we've largely been successful with that. We've had our students back in the clinical world since June, and we've not had a single student convert to COVID positive yet.
Great. So themes of quick pivoting and sort of mixed success. We can revisit everyone's impression. Others, please. Comments? In what ways has the pandemic caused you to change your educational approach? To which educational audiences and how so?
Yeah, we've had a similar experience. I think we had to rapidly convert to online learning for pretty much all our offerings to our students sometime around March. That was prescribed really by the authorities here, by the Ministry of Education. For the clinical students, the students who are in their clinical clerkships, we had to pull them out of the clinical settings a bit later. I remember that there was a lot of discussion around, well, do we deprive them of the opportunity to learn from such a crisis? And that had to be balanced against sort of their safety, them sort of adding to the transmission dynamics of the virus. There's also the issue of the availability of personal protective equipment and how do you use those resources for frontliners who are actually taking care of COVID patients. That had to be considered. The thing that really made that decision less difficult to take is that at the peak of the pandemic, at least at the first peak, it became clear that even if we leave them in the clinical environments for them to learn from this experience, the faculty, the clinical faculty, perhaps didn't have the time that they usually had before the pandemic to focus on education. So really taking care of patients. So the thought that it'll be a unique learning experience was less likely, given the fact that the clinical faculty were actually busy taking care of patients and taking care of a disease that we didn't know much about at the time. Things have gone back pretty much to for the clinical rotations, pretty much to pre-COVID settings for the clinical students. For the pre-clinical students, we're still doing a lot of online virtual with some on-site small group and team-based activities.
So an experience, if I understand, Alawi, quick pivoting, sort of a diversion of energy to focus obviously on the crisis at hand, some triaging with regard to personal protective equipment that all of us faced early on. I think we've all addressed those PPE issues much more fluidly now, thankfully, with some time to respond. And again, I hear you describing, as Bud did, sort of some mixed reviews, some triumphs and some continuing challenges. Is that fair?
That's fair. I think overall, I think it's been, looking back, I'm surprised on how relatively smooth the transition took place. And I think that speaks to the, perhaps to the resources that were there that we were not probably utilizing to their max. And we were sort of forced with this pandemic to actually utilize what we have. It also made us realize that the audience could very, very much be beyond our students. Going back to your question about, how did this change your audience in terms of learning and education? And I think the community became a very clear learner, really, for academic institutions and medical schools to communicate with.
Yes, indeed.
We very quickly put together an online module for sort of breaking the chain of infection, labeled it as a community immunity program, and released it in several languages. Now it's available in 5 languages, and that was released sometime, I think, late March, early April, and we've had more than 1 million users globally. So we suddenly realized, hold on, we didn't change anything in terms of our resources. It's the same people, it's the same resources, but all of a sudden we have 1 million learners around the globe.
Yes.
We didn't think like that. And I think moving forward, so we're asking ourselves, how do we leverage these resources now to be more proactive in terms of a global community of learners?
Yes.
Beyond sort of the on-campus students that we have.
Yes, I think we've all come to that realization. Elias has been pivotal in developing, in colleagues in the Respiratory Institute, my colleagues, collaboration in which we've really jointly developed COVID materials. And perhaps in your comments, Elias, you can address that as well. And Cecile, of course, has been pivotal to that effort. So I might turn to both of you to comment on this question, as well as the question that Alawi has brought up about external communities of which we were unaware before. Please.
So what I would like to say here is that dealing with residents is evidently much different than dealing with medical students in their roles as caregivers, active participants in taking care of the patients. And something we are facing again now, which is the redeployment of residents from their roles as learners and training in their own specialties to ones who are going to be part of the bigger team of taking care of patients as they come into our systems. We were fortunate that the first wave of COVID-19 patients did not overwhelm our system to the extent that we needed to mobilize trainees to take on different roles that they signed up for initially. And I hope that we would not go through that now, but across the country, and I bet across the world, there have been a lot of institutions where the residents had to learn new things, take on new roles, and perform as physicians and caregivers. They're part of the taking care of patients afflicted by COVID-19. So I think that's all I'm going to say for now, and I'll pass on to Cecile to describe maybe a little bit how we also took the opportunity, as Jamie mentioned earlier. We did not waste this crisis, and we tried to make the best out of it to assist in training our own in what they needed to do in the crisis, and participating, like Alawi said, in training people around the world to do the same.
Great.
Absolutely. So I think, going from an educator's perspective, one of the things I observed that was most visible was the shift in attitudes of faculty, that willingness to explore, to try and fail and be flexible. I recall years of trying to implement technology and people would push back, focusing on the barriers, or thinking that because we at Cleveland Clinic love face-to-face events. So this really pushed everyone to the limit. Everybody stepped up to the plate, and at amazing speeds. The collaboration between clinicians, educators, and folks from our technology department were able to pull together amazing amounts of educational materials to help others in adapting to this. The things included, how to not only how to treat patients, but what are the processes for staying safe and protecting themselves, guidelines and things that were changing literally on a daily basis, and then were being posted with this was updated at such and such time. And just the speed with which we were able to turn these things around, I think demonstrates that we have been missing an opportunity to leverage that technology, to leverage the resources that we have. But when we were put on the spot, everybody stepped up, and it was a fabulous collaboration.
And as we turn to Sawsan, I might just ask you, Cecile, to comment as Alawi has with regard to their discovering a new community of learners, the effort that went on to develop COVID resources, both for our intramural audience to upskill doctors in anticipation of being deployed to areas that are outside of their usual clinical responsibilities, as well as to an external audience. You might, since you were pivotal in developing that, I might ask you to comment on those materials and their impact and uptake.
So we saw this amazing response to the materials that were posted. Right? We had about 200 different modules that had information on redeployment. If you're coming from a pediatric unit and you were going to be put in this having to take care of COVID patients, what would you need to know? What would you need to do? So there were hundreds of thousands of page views for each of our resources. It was, again, just mind-blowing to see the uptake. People took the time to review the materials, to actually inform themselves, to share. I think the ability to just openly share all of your knowledge, give to others without expecting anything. We made these resources available to the public for free. We have a website that has people from 120 countries, I believe, have viewed our resources so far. And I think the speed with which was developed and I think the force behind it, right? The willingness to share information. I think that was what was more the most moving part of all this. Everybody really went in together. It's like, let's share what we know, give it to everybody else so everybody can benefit, so that we can work on this together. And I think that was the spirit, and it was great to be part of that.
So amazing sort of internal collaboration. I think the number was 378,000 page views by 28,000 caregivers within the Cleveland Clinic, and then of course turning this externally. And I might, Cecile, if you're willing, put in the chat box the URL for the external resource. Sawsan,
I was just looking for that, yes.
Yeah, Sawsan, you have deep experience with this. I wonder your thoughts about this first question.
Yeah, no, I have to say, so a lot of what our colleagues have said are actually applied to many different places in the world. I will say, as Elias has said, you know, the unique challenge with residents is that they're professionalized and they're part of the workforce. And so you have to balance the service sort of requirement of them in you know, potentially challenging situations, and at the same time, you know, foster a continuity of learning. So some of the things that we've used, of course, the online resources that everyone's talked about in terms of both the delivery of educational material, but also for their operational needs, such as morning reports, or, you know, things that usually are done face-to-face, or M&Ms and so on. We've also developed, you know, the idea of developing very quickly online content that could be used across specialties, and sort of joint efforts was also something that was really quite remarkable here. We were lucky, just as you were, in that we never, our capacity, or sort of our needs never sort of stripped our capacity in terms of our faculty being able to deliver clinical services. So our residents were not put in a position where they had to you know, be caregivers and not have the appropriate supervision, PPE, and all the other things that the other parts of the world suffered with. But I think some of the things that we found that were really, really helpful is, one, engaging in discussions with our regulators very early on, and our accreditors. And so the people who generally put standards were willing to listen and hear from the ground up to see what was happening and what were the actual, you know, practical challenges that were facing medical educators and trainees. The other piece was that, you know, little things, altering shifts, scheduling, putting forth sort of non-clinical rotations, for, you know, earlier on in the curriculum, so research or other places where they could work, and also fostering the sense of sort of pride in their profession, right? So that was a very big part of what we did as well, right? So having them involved in COVID responses that may not have been sort of patient facing, but, you know, contact tracing and all the other things that were so pivotal to the response. And of course, essentially it came down to just the continuous daily consideration and their day-to-day operation and clinical tasks being assigned to these trainees. You know, the continuous consideration by their faculty as to whether whether what we were asking them to do fulfilled the learning objective primarily, right? And also put that in the context of, you know, PPE stewardship, appropriate supervision, and all the other things that you need to do to ensure that they're having that exchange, that learning exchange in the safest manner possible. So for us, it was the constant sort of revision and consideration by faculty on a day-to-day basis about what they were asking their trainees to do.
Fabulous. So themes that I've heard all of you say are quick pivoting, and incredible nimbleness and collaboration, both within the organization and, as you've pointed out, Sawsan and Alawi, collaboration with government and with ministerial oversight, so that there's coordination to support that nimbleness. And then, of course, on the faculty side, the balancing of service and education, which is, of course, the same issue we face even in pre-pandemic times, coupled with this new issue of resource allocation, PPE, and so on. So big themes, new audiences, new technologies. Let's turn to our second question. And Sawsan, you're on a roll. I'll ask you to perhaps respond first to this. And I'll just read it again. We've answered some dimensions of this, but there are opportunities to be a little bit more granular about the specifics of how we've taken this on. So what has been the impact of the pandemic on virtual education? I think we have all stated that it's been a boon to virtual education, evidence of the fact that we're on a webinar now, which was also prompted by this. How are you using virtual education currently, and with what impact? And any specific recommendations about approaches to virtual education, specific platforms, and specific techniques? And I know there's a wealth of experience on the panel in all of these questions, and I'll invite Sawsan to begin and then others to follow, please.
Sure. I may broaden it a little bit and say not just virtual education, but sort of virtual technology and how we deliver education as
Perfect.
well. You know, I have to say it's been quite a large impact, I think, for all of us on a personal level, of course, with what we do now. But from a teaching learning exchange standpoint, one of the things that we found, of course, is that one, utilizing these online platforms has allowed us to promote the use of asynchronous learning. As you know, that's not something we do very much in residency. I think medical school, we do that a little bit more often. So that's been a nice realization for a lot of us, right? So the idea that, you know, lectures really could be held at their, you know, at their comfort or at their convenience, of both the speaker and the trainee. Also, as Cecile's mentioned earlier, the idea of resource sharing has just been so much easier using these online technologies. So this ability to disseminate our academic innovations, the ability to resource share, and in fact, you know, essentially content becomes less proprietary, which makes, you know, sort of this idea of accessing medical education so much more egalitarian, right? So it's phenomenal. I think it's such a nice move, or shift that we're seeing you know, in how we use technology. And I think also, when I think about it, there are certain processes, if we think from an operational standpoint, then the online platform has really made us think twice, right? So things like residency interviewing, right? So all of us were, you know, face to face. Now we're all thinking, do we really need to see everybody and make them pay all this money to fly in and see us, right? So I think even processes behind our educational programs have been revolutionized, right, through virtual technology. And lastly, and I'm going to say this because I know there's going to be so many great thoughts about this from other panel members, I don't want to take up all the time, but how we deliver care. Right, so that's really sort of the crux, right? So we all know that we've moved to virtual sort of health and remote visits with patients, but of course that's going to have a significant impact on what we teach our residents. How do we assess patients from their homes, right? How do you look at the physical exam online, right? How do you come up with a management plan? How do you leverage community services that can then you know, help you with your management and diagnostic sort of steps? So I think these virtual platforms are actually going to change quite a bit of how we educate our students, and we're just starting to see the beginning of it. So I'll stop there and let others pitch in as well.
Fabulous. So themes that I heard you say, and others will pick up on, of course, the sort of democratization of education, I think, which has been a boon. When Alawi pointed out that there's 1 million uptakes for the materials you've presented, that's the pinnacle of democratization of education with the community. Obviously, the pivot to asynchronous learning, the fact that people can access this as they like, when they like, which is, of course, important to our trainees who are busy, working under 80-hour work duty rules and so on. And then the idea of this collaborative spirit, as well as the new paradigms of care, virtual care. So those themes are in play. Again, the question about specific recommendations about approaches to virtual technology platforms and techniques. Let me invite comment from others.
So I'll like to build on what Sawsan just said about, you know, the virtual affordances of online education. I think there is one component that has most educators trumped, right? What do you do when you are teaching these little black squares? You know, when people don't actually turn their cameras on and you don't know who you're engaging with. That has been one of the most disorienting, I think, aspects of this, you know, technology to educators. So, you know, human connection being at the core of how we learn, it is really difficult to replicate in a virtual environment. So there are things that, you know, you can do to kind of facilitate those connections, you know, taking the time to do like check-ins at the beginning of a session, and you really have to make an effort to get to know them, being aware of their demands. You know, clinical workloads are, you know, extremely high right now. So making an effort to, you know, be as flexible as you can, acknowledging their individuality. You know, sometimes you want them all to turn their cameras on. You always encourage my learners to do so, but you have to recognize that not everybody's comfortable doing that. You know, let them participate however they want to, ensuring that everybody's on the same page. You know, setting clear expectations, orienting people to the tools you're going to use. Not everybody's familiar with the tools you're using. Some things are very new, so making sure that everybody is on the same page. And demonstrated that you value your time. If you're going to bring them together for synchronous education, don't just lecture at them. You have to actually create opportunities to actively engage them in participation. I think creating opportunities for people to work together, that peer-to-peer interaction is key in a virtual environment, because you have to create that sense of presence. You have to create that sense of community, and you have to actually go out of your way to doing this. And I think that's one of the things that has come out of this. People that are engaging in online teaching have recognized the importance of creating these connections and really be purposeful about generating them.
So intentionality, and I think I've learned from you and others that when we're conducting live synchronous and then subsequently asynchronous, to Sawsan's point, teaching sessions, we want to punctuate that with interactions fairly frequently. Every few minutes, a chat, a poll, a breakout room, an annotation, a whiteboard, utilities that we've all become conversant with in Zoom, for example, or Teams, or whatever your platform may be. That sort of intentionality about reaching out when you can't read the faces and the body language in the room. Lovely. Other comments about these points, about techniques and things that we've learned, please?
I might add, our students, not surprisingly, picked up on all this much more quickly than our faculty. And so at the medical school level, we had to do a lot of support for our faculty. That was probably one of our biggest challenges early on. And we actually, out of this, grew a faculty development very focused on how to use Zoom technology when you're leading a seminar or small group. So that was one lesson that came away that was really important. I think one of the benefits that we've seen is for educational activities where you invite people from a wide spectrum to attend. Typically, when you ask them to come in person, it's mixed in terms of the attendance. So we have an education grand rounds, for instance, and the attendance with a virtual platform has just grown exponentially. It's much easier for people to access from wherever they are without the transport, time and all that. So I think faculty support has been crucial to help them succeed. We've also found, I think, to replicate a small environment, the breakout rooms have been essential. And so we've used breakout rooms and that really has allowed people to have interactions in small groups. It's actually quite safe too. And so in some ways that's been an unexpected victory in all this.
Alawi, Elias, other comments on this question? I have some follow-ons, but let me invite your comments.
No, I was just reflecting on what the colleague said. I agree with all the recommendations, the breakout rooms, the frequent interruptions. But it's interesting, we're forced to think that way because of the online learning and this sense that how do we know that the students are engaged with us or not? But on-site learning, physical presence doesn't necessarily mean engagement. And these same techniques, the frequent interruptions, the breakout, those are the same things that we need to think about also with on-site learning. Even if you have them all in a classroom, it's still worth thinking about these things to ensure engagement and to enhance engagement.
Yes, you're reminding us that we've sort of reverse engineered this in the sense that we've learned some things from virtual teaching that we should have known when we were live in the classroom. Instead of the sage on the stage, we've morphed to flipping the classroom and other strategies that we've all sort of has been underscored. So when we do restore to a more normal face-to-face environment, we should capture these and continue these lessons. I hear you saying.
Yep. Exactly.
Yeah. Wonderful. Thank you. Elias, other thoughts about this?
I think most of it's been discussed. The only thing that we did not touch upon so far, maybe later we can, and maybe I can open the door for it, is telemedicine and its role in teaching, not in teaching, but its role in the or its use in teaching and in the delivery of care. And I know our medical school colleagues have developed a curriculum for that, at least for an elective in it. And I know that many of our training programs have used it. Some of it has stuck and some of it has kind of faded away now that we're, at least we were back to a more or less normal clinical delivery environment. But I think some of it will stay with us. And we will need to adjust our curricula going forward to include it. We can reach evidently more patients with it. We could be more efficient. I personally like the virtual environment in communicating with my colleagues, in communicating with my learners. Somebody mentioned, I think it may have been about the number of people participating in our educational activities has skyrocketed. At grand rounds at the Eye Institute, now they have 70, 80 people. We used to struggle to get 20, 30 because, you know, when you plan your day, you have to build in the time to move. It produces an anxiety in us. So what am I going to do next? What am I going to do next? Whereas if you know, oh, you know what, I'll be able to make that because all I have to do is just turn my phone on and join, and I'll be there and whatever. So we've talked about this before, Jamie, but but this is really the very thick silver lining to this crisis. It allowed us to learn new things and work it back and reverse engineering, as you said, and Alawi said, to our face-to-face on-site learning and teaching environment.
Yeah, so you've raised the question that Sawsan also brought up, the two dimensions of the virtual environment. One is teaching our trainees and our students how to use this technology, and teaching our faculty how to teach in a virtual environment, number one. And then for all of us as clinicians, how do we actually care for patients? I was struck by, I received a manuscript from one of our medical residents about a patient that we had seen with a COPD exacerbation that we had seen virtually. And as Sawsan pointed out, you know, as a lung doctor, it's hard to auscultate the chest. And so we depend on some indirect things like looking for accessory muscle use and actually counting the respiratory rate and looking for clubbing and, you know, sort of some indirect things that are a minimal exam, but that inform our clinical impression. So it's been an experience for all of us. So some very common themes. Let me turn to the third question, and then I'm aware that we have some questions from that have been submitted, but I'll invite everyone to put questions either in Q&A or in chat. I see some comments in chat already. The third question, and Alawi, perhaps I'll ask you to take lead on this if you might. What educational opportunities, innovations have resulted? Of course, we've talked about some of these already. These questions are in a way redundant, but it is an opportunity to cover the waterfront. So what innovations have appeared incremental to what we've discussed that you want to share with our international audience, please?
I think, you know, in addition to the technology enhanced options that we've been discussing, you know, over the past 5 to 10 minutes, I think I would consider innovation in the behavioral changes that are, you know, that both the faculty and the learner were sort of had to go through to adapt to this new environment. And I hope these would be sustainable and long lasting. So that would be my answer to that one, James.
Right, some hopefully long-standing behavior change, just like
yeah,
your
so
comment about
that's
the
a big
pedagogical
question.
approach. Absolutely.
Yeah, how do we make sure that this is sustainable? I think that's what many schools are thinking about now.
Yeah.
As things go back to normal, we don't want to go back to the old normal in terms of our teaching and learning.
Absolutely. Others?
I think there's an opportunity for that, for faculty development, right? I think people were thrown into this without the skills, without the time to develop instruction in a meaningful way. Some things were done better than others, depending on the level of experience the faculty had. So I think this is an opportunity to build on this embracing that everybody now is okay with technology. This is no longer the whether you should or not, you know, now is how do you use it best to support the learning that you're doing in other places. So I think really capitalizing on this in terms of faculty development, giving them the skills, the technical skills to make things happen, and the support they need to make these things happen, right? Having the infrastructure, having the tools that allow collaboration and information flow, all of those things I think will be where we can focus on for the future to build on it. And this is not a short term, we had to use it and then now we can go back to normal. I think we literally can use it to enhance what we're doing in the classroom already.
Right. So Alawi is inviting, and you're reinforcing the idea that there is a silver lining, Elias's words. And shame on us if we can't carry these behaviors forward to the new normal that we will face, hopefully post-virus. Sawsan, looks like you have a comment, please.
Yeah. So one of the thoughts I had, putting on sort of my old regulatory hat and thinking maybe a little bit outside of the day-to-day education operations that we're all involved in, is I honestly think this is a huge opportunity. This presents a very large opportunity looking at sort of valuing workforce planning, right? Things on the regulatory level, valuing the sort of the role that trainees actually play in the health system. And it gives us an opportunity really to highlight the importance of a lot of things that we all know are not working out very well in many parts of the world. You know, how do we allocate resources towards a healthcare workforce that's equipped with the health needs that are required of, by populations? How do we rethink funding of medical education and how we, and how we prioritize that in national sort of agendas? I think this really gives us, as educators, if we step a little bit outside of our institutions or our day-to-day, gives us a chance to think about how do we advocate at a larger level, since this pandemic has sort of provided us with the value proposition here to people who are really the decision makers in all of our systems. And so how do we leverage that? And I think that's a huge opportunity that we can all think of as well.
Right, the notion that there's opportunity in a crisis and we should capitalize on that. Lovely. Other comments?
Yeah.
Bud, please.
I would just say one thing we haven't talked about is the need to maintain connectivity as people feel isolated in the pandemic. And so we actually switched to most people in our support team working from home. And we found that the virtual platform is a way to stay connected. So we've had town halls several times a week. We've actually engaged in wellness activities for our students. We've had virtual dinners where people can be safe, isolated, but still the sense that they are connected, because I think there's really a risk of isolation in all of this. So I think that's another thing we've learned. It's a way to stay connected.
Yeah, so one of the things actually Cecile and I were reflecting on yesterday was, one of the upsides of all this, and we've been talking about it, is the technology and the efficiency, as Elias pointed out. But one of the downsides is that we lack what I've called collisions, right? You go to a lecture and you're sitting next to a colleague, and as you leave the lecture and are going back to your office, there's a hallway conversation that's full of sort of not only pleasantries, but actually generative of ideas and collaborations that emerge from those spontaneous collisions that we're missing. And so my invitation to colleagues in the Education Institute is not only to participate in all of the very many conferences we have that are virtual, but just pick up the telephone spontaneously and call a colleague to check in on them. So we maintain some of that spontaneous connectivity, I think very, very important, because at the end of the day, as Cecile has reminded us, it's human connectivity, whether it's education or clinical practice. The work of Jody Gittell, I'm sure you all know, relational coordination, our effectiveness in providing care is predicated on the relationships that we have and how do we leverage those, particularly in team environments in which we all practice. So we have to preserve, that's another admonition that Alawi has reminded us, we have to preserve the best of clinical practice in this new world, which is informed by our virtual environment. Elias, please.
Just to pick up on what Sawsan has brought up, Sawsan, we have put together a group of several of us who are thinking about this post-COVID-19 education. And one of the themes that we discussed the last time was indeed planning for the future, for the needs of our institution, for the needs of the state, for the needs of the country, how we could be more parsimonious in the use of time that people spend in training, what specialties we need more. So I think it is, as you said, very wisely, one of those other major opportunities to rethink the traditionality or what has grown to become the way we do things. So, it's just one of those disruptions that we have to take advantage of and plan in a better way. And I think this particular topic, since we have such a large international group on the call today, will vary from environment to environment, from country to country, from so on. So I invite every group to take a look within their own country and state or wherever they are, to see how they want to revisit this, take advantage of the technology, of what we've learned, and just take a fresh look at things. It's always good to do that.
Wonderful comments. So we've sort of addressed the questions we've posed, but I want to take advantage of the wisdom and curiosity of our international audience. And we have several questions that have been posed in advance, but let me address the questions that are in the Q&A box, and I'll read them. There are two currently from Juan Pellerano. What's the future of virtual medical education? I think we've indirectly addressed some of these issues, but perhaps in rapid fire sequence, because there are several questions I would like to get to be responsive to everyone's input. What's the future of virtual medical education? Any comments?
I think, as I said before, now that we have embraced technology, I think we can use it to supplement what we're already doing in a traditional way. I think that's the opportunity.
Yeah,
and we're gonna have a hybrid model in the future. We're gonna take the best of what we've learned, continue that, while then reintroducing in person when we think that's a better method.
Yes, and then picking up on both Alawi's and Sawsan's comments, the notion of asynchronous learning and carrying our behaviors beyond back to the live classroom, that's also the future of virtual medical education, is capturing those lessons. Lovely. Any other comments about this before we turn to our next question that's come in? There are now three. A second question posed: is there any concern that we might be graduating or promoting students about whom we're unsure of their clinical competence? We're all focusing on entrustable professional activities, EPAs. The questioner is because we couldn't examine them clinically or because they missed out on key clinical rotations. Any concerns there? Comments?
I think that's a valid concern, but I think I believe there's enough flexibility in our current medical education system to compensate for that. If you take undergraduate and postgraduate medical education together as a continuum, we haven't touched much on assessment and how these how technology and these changes and will affect sort of our thinking of assessment, and there could be an opportunity there, just like on how we deliver medical education, but how we assess students. There may be an opportunity here for us to rethink really what is it that we're assessing and how are we assessing it.
Sure, virtual OSCEs and
virtual OSCEs.
In a way, Sausan has opened this question about virtual interviewing. That is the ultimate assessment, isn't it? You're assessing candidates by looking on a two-dimensional screen and incorporating behavior-based questioning, and those sorts of things become yet more critical in a virtual interview environment. And we have to teach our trainees. We are doing that, as I'm sure all of you are, teaching them how to interview both our medical students and our trainees looking for fellowship in how to engage in a virtual environment. Paying attention to the lighting. You can see the sunlight is coming in on my face and making me look very anemic right now. If I were interviewing, I'd be paying more attention to that, right? That sort of thing. So please, Elias.
So I think this question of assessment is extremely important, and it ties to one of the questions I read here in the question and answer box. We have to at the end of our graduate medical education training, and I will not comment about medical student ones, entrust our graduates with taking care of patients independently. And that's the whole purpose of them being in our training programs, not only to pass their boards and take an exam or answer a question, but to be able to take care of patients. And that, I don't know how affected that's going to be, because they will continue to be in the hospital and in the clinic and taking care of patients. We need to concentrate more on training our faculty to do better assessments. And to that effect, I think there was recently a tool that was released by the ACGME by Eric Hornbow and his group. That's a tool that an app that you can download on your phone for on-the-spot assessments in different clinical situations that then the program director can utilize. So I invite everybody to take a look at that, and invite everybody who's responsible for large groups of training programs or educators to concentrate more on training them in methods of assessment and modify those methods of assessment in view of the current environment and the impact of COVID-19.
So building on Alawi's comment that we need to take our lessons from the virtual environment forward and not forget those. The criticality of assessment skills has always been, providing feedback. How to provide assessment to our trainees has always been critical, and probably a shortcoming that we've all been challenged by. But this really brings it into a high focus, I guess we'd all say. Wonderful. Other comments? There are other questions I want to make sure we address. I am mindful that we have addressed some of the questions that have been submitted pre-registration, but a question comes: how do colleges provide psychosocial support to students and identify students at risk of anxiety? So Bud touched upon the importance of wellness, but perhaps a comment from everyone about how do we attend to students' wellness in a remote environment?
I could maybe expand. We actually designated one of our faculty, even pre-COVID, to be in charge of wellness for our students. We recognize it's a very stressful environment. Really, one of the biggest challenges, we had a new medical school class starting in July, and they really couldn't come together in the usual way in terms of being together as a community. So we've had a lot of activities that have happened through class meetings, virtual meetings, and we actually have a lot of very focused, intentional activities on wellness. We actually have a wellness app developed internally that the students can put on their phone with various activities. And the students have gathered outside safely, physically separated, to do some activities. We also have recognized and assigned behavioral health specialists for our students and make them available, not in the context of providing actual medical care, but just counseling and as an outlet to direct and really triage those who may need professional care. So those things, I think, is just, you have to have it in the forefront of your mind. It's actually a very critical point, and keep that top of mind all the time, the wellness of the students and the tendency to become isolated.
So intentionality about it and resourcing it, giving specific roles, goals, and responsibilities to people that are focused on student wellness. Fair enough. Other comments about wellness?
So I think it's a great question, because as we become, a lot more instruction goes remote, it's much easier for students, maybe not residents so much because they're delivering care as part of their job, but for students to actually self-isolate and sort of withdraw. And it's harder to see that when they don't show up to class anyway, right? And I think we've all seen that. There's this tweet that went out about, I think one of these medical school professors took a picture of his classroom. And I think all of us were like, what? The classroom is empty, right? Because we are just not used to, we still think about when we went to medical school and how the lecture hall was really where everything happened. And so, I do think about that, for these professors, how do they know what's actually happening in their students' lives when they see them as often, actually? And I think all it does is essentially highlight, I think, the role of peers, right? And the role of, ensuring that students, trainees understand, how to look for signs of colleagues that are unwell. The importance of connectivity, we talked about that today, human connection and fostering it in different ways, ensuring that they do have fora or opportunities to meet. But it is hard. I don't think there's a single right answer here as to how to do it as we become more and more virtual in our interactions. I do worry about that.
Yeah, so the risk of isolation and the sequelae of isolation, very, very, very important. Let's turn to our fourth question. They're all sort of related, which is, of course, not surprising. So given the scenario of minimal face-to-face communication with patients, how could we make sure that students acquire core humanistic values and hands-on clinical expertise in procedural skills? So comments on procedural skills, I can certainly address those from the SIM Center perspective, but let me invite your comments.
I would like to make a comment about the humanistic values, and I'm going to be a little contradictory here. I think that sometimes, and especially when it comes to certain social and cultural backgrounds, and we have people from all over the world, it could be that their core humanistic values actually are better if they don't come to the hospital, because from within their families, from within their communities, they may be higher than coming and being blasé after years of being in the hospitals and being in touch with others. So I think that is very cultural and social related. And I see Alawi shaking his head because I imagine that is the case in the UAE, for example, or other countries. From a procedural skills perspective, I am not worried at all. I think a resident can graduate, and we're talking here about medical students, I think, when it comes to this question, but they are going to learn their procedural skills in their residency. And if they don't learn them in their residency, they will learn them they will refine them when they go out to practice. I think it's important that they do get the basics. Simulation has helped us quite a bit with that, but they still have to practice on patients, and they will do it during the residency. So I'm not worried about it at all.
So Elias, as usual, wonderful, appreciative perspective that we may be more humanistic working remotely. Fair enough. It's a wonderful point. Other comments on this question?
Yeah, I do think there is an opportunity to leverage on telehealth medicine technology to do some of this. For example, they could shadow virtually clinicians, right? They could actually see how seasoned clinicians do histories, how do they take care of patients, so they could join the calls and use that as an opportunity to get some of those skills. How do they convey empathy? How are they treating their patients? So there's, even though I agree with Elias that they will learn it and they will get this, there are still opportunities to kind of leverage on some of the existing tools.
Communication skills, definitely, yes.
So Elias, there's an invitation for you to share Eric Holmboe's app or some URL to it, if you might, and I'll invite you to do that. Perhaps share it with the entire community if you would.
Yeah, I would just make a comment too about it. It gets to the assessment, how we know we're graduating students who have the skill set and the competencies we want, as well as maintaining the human connection. And I think what Alawi and I spoke to at the beginning is we had to get our students back into the hospital. We cannot insulate them. They're in a profession that doesn't run away from crisis, it runs towards crisis. And so we have to be mindful and do it in a very thoughtful way. But given the proper PPE and the right environment where we're trying to not intentionally have our students take care of COVID patients if we can avoid it, although that's even becoming more difficult, we still value and we assess our students on the human interaction. And so we assess them on how they interact with patients. We have observations based on that. And I think it's a great question. It's absolutely critical. The students still need to engage with the patients. And we try to do things like presenting patients at the bedside and really reinforcing that. In the virtual world, I think the idea that you actually have a video connection is important. I've actually been involved having students in clinic with me. And when you can see a patient, it's still not the same as being in the room, but you can still make that connection. And you can observe how a student does in the video virtual world as well.
Well, I'm mindful we're at the hour. I want to just try to summarize a few themes that I heard, and then of course thank all of you in the audience for attending and our esteemed panel. I heard themes around intentionality, that this provides an opportunity to be explicit and mindful in our design of curriculum, and the opportunity to extrapolate the learning that we've had in this crisis to our teaching educational lives thereafter. That will be, as was pointed out so nicely, as a hybrid environment. We'll continue to have asynchronous learning and synchronous learning. We'll continue to focus our assessment skills both two-dimensionally, virtually, and three-dimensionally, face-to-face. the incredible opportunity on collaboration and nimbleness and connectivity and preserving a social fabric, and the importance of wellness and connectivity with our students and frankly among ourselves as faculty, a very important takeaway. And the idea of nimbleness, the idea that I'm a big fan of thinking about organizational culture, and crises like this are tests of our culture. They're tests of our ability to reach out to colleagues both within our environment and outside of our environment. Alawi reminded us that there are communities of millions outside of our world that we are now connecting with in ways in which we weren't perhaps before, and this crisis has reminded us of both the mandate and opportunity to do so. So lovely dialogue. I have to say, I can't imagine a more robust dialogue by a group of better experts around the world. And of course, the world is represented here, both in our listeners and in our faculty. I'm incredibly indebted to all of you, not only for participating today and sharing your wisdom with the world, but also for the work that you're doing in Abu Dhabi and Dubai and in Cleveland and all over the world, as our listeners are. We are all engaged in a collective enterprise of responding to a world crisis, taking care of our students, taking care of each other, taking care of our patients. And so with that, having gone over a couple of minutes, but with thanks for everyone's indulgence, and thanks to Chilla Myers and Leah Bowens for helping to organize this, I want to say we're all available. I will put my email in the chat box before we shut down, and I invite any of you that are available to do so as well. And I'm sure we'd be delighted to engage with you in an ongoing dialogue around this. So I'd like to thank you all for joining us while I divert my attention to type my email and others. Again, my deep thanks to the panel and to all of you for listening. So I think we're adjourned. Thank you so much. Thank you.
Thank you, everyone.
Bye-bye. Take care.
Bye.
Thank you.
Thank you so much.